Hi and welcome. My name is Joe Macaron and I'm a practicing oncologist. I want to record a series of educational videos about topics that I frequently discuss with my patients and colleagues. This is my first video and it's going to be about non-Hodgkin's lymphoma. So feel free to leave me any comments or suggestions in the comments section about things you want to know more about. Also, feel free to give me tips or software suggestions about how to record videos and podcasts because I'm kind of new to this and I honestly have no idea. And it seems to be a lot harder than what I thought. So let's get going. So first, just let's get the formal things out of the way. So today is the 25th of February of 2023. I am a practicing oncologist. However, this is not medical advice. I cannot give medical advice over the internet because comprehensive and responsible medical advice includes getting a lot more information than what you can send me over a message over the internet. I'm also employed, but my employer has not reviewed this material and has nothing to do with this. Finally, this is my own interpretation and recollection of what I know about this topic in general. It took me years to accumulate this information, and I and the scientific community continue to learn about these topics, and our views and opinions and facts will change. This is just an informal summary of the highlights that I think would be helpful for people to know. All right, so let's jump right into it. What is lymphoma? So, lymphoma is cancer of the white blood cells. What are white blood cells? White blood cells are cells made by our bone marrow and the stem cells in the bone marrow to fight infections. So let's take a step back and explain what all of this means. So our body is made of many organs, and the bone marrow is one organ. Its job is to make our blood. So every day it's making new blood cells that are these stem cells inside our bone marrow, and they divide and they make one extra copy of themselves, and then another copy that is a baby cell of some sort that grows up to become either a red cell or a white cell or platelets. Now, there are broadly two families in the bone marrow. One is called myeloid and one is called lymphoid. Just like Smith and Jones, myeloid, lymphoid. The myeloid family includes red cells and certain types of white blood cells and platelets, and the lymphoid family includes only white blood cells. The lymphoid white blood cells are given letter names like T as in Tony, B as in boy, and NK, which stands for natural killer, like Nancy King. So these cells grow up and then they leave our bone marrow and they start swimming in the blood. And for some of the white blood cells, they need more education. They need more specialization. They have to encounter, viruses and bacteria and fungal elements that they learn to respond and adapt to and remember. So sometimes they're just swimming in blood. Sometimes they go to organs. If we have a pneumonia, they have to go to the lungs. If we have a skin infection, they have to go to the skin. But a lot of times they just sit in lymph nodes. And so this is a picture of sort of all of our lymphatic system, which is the set of tubes and pipes that transports this lymph fluid, which contains these lymphocytes just all over our body. And there's these little stations that they stop by called lymph nodes. That's where a lot of the lymphocytes just stay there. They train, they mature, they grow up, and they learn how to make antibodies or how to better fight infections. And so, what are some of the risk factors for getting lymphoma? We don't know of a lot of risk factors, and certainly there's not a risk factor that is a home run. There's nothing like smoking and lung cancer, for example. There are some minor, smaller risk factors. The association between these risk factors and developing lymphoma is somewhat low or weak. So one example is, these certain situations where we have chronic inflammation can lead to lymphoma. Some of these situations include infections, sometimes with viruses, sometimes with bacteria. For example, hepatitis C can predispose us to lymphoma. Other examples are if we have an ulcer in our stomach caused by a bacteria called H. pylori or Helicobacter pylori, that can also lead to lymphoma. Sometimes if we have an autoimmune disease where we have a state of a chronic inflammation, a lot of inflammation, such as Sjogren's syndrome, that can also lead to lymphoma. Sometimes treating autoimmune diseases when we suppress the immune system or other ways that we can suppress the immune system, such as HIV or AIDS. These can also lead to lymphoma. There are some substances that can lead to lymphoma and have been associated with lymphoma. And very rarely there are some inherited types of lymphoma. But overall, I think all of these associations are fairly, they have a small magnitude. A lot of people have autoimmune diseases or take medications for autoimmune diseases, and very few of them develop lymphoma. But it is more than what we see in the general population, so that association is real, even though what it means is that we don't know it's probably multifactorial, and there are other factors that we don't know about in the development of lymphoma. So what I generally tell people who are first diagnosed with lymphoma is it really is somewhat of a bad luck. And that kind of means that we don't know why they got it, but in general, this is sort of our explanation in this day and age. Let's advance the slide here. Now, there are many different types of lymphoma, and there are many different ways where we can classify or group lymphomas together. So the most common type is this division between Hodgkin's and non-Hodgkin's lymphoma. Now, this video is going to concentrate on non-Hodgkin's lymphoma. And this division is also sort of, a little bit funny because there's only very few types of Hodgkin's. In fact, one can say that there's only two types in the way that we treat them. But there are many different types of non-Hodgkin's lymphoma. So it kind of feels a little bit, Hodgkin-centric, if you want to think about it this way. Now, the non-Hodgkin's lymphoma can also be divided in many different ways. We talked about these different types or names of lymphocyte. B as in boy, T as in Tony, NK as in natural killer. And this is one way that we can divide non-Hodgkin's lymphoma into. So B, T, NK cell, non-Hodgkin's lymphoma. There's also some mixed types such as NKT. Another way that we can group them or look at them is how they behave. What do they do in a person? And some are indolent and some are aggressive. And that does refer to sort of how quickly they grow, how quickly does somebody feel them coming on, and what kind of changes do they make to the body. So aggressive would be quicker, more acute. Indolent would be slow growing. People don't feel any changes overnight. There are some other types of lymphoma. For example, PTLD is post-transplant lymphoproliferative disorder. It's a type of lymphoma that happens after transplant, after somebody receives a type of transplant. Generally, it's sort of a solid organ transplant, such as kidney or pancreas or liver, where they require to be on medications that lower their immune system, rejection medications. There's one last type of lymphoma, or one important type of lymphoma to discuss, called gray zone. And gray zone means neither black or white. It's when we have these types of lymphoma where a pathologist looks under the microscope and they cannot give us a clear name. And there are some reasons for that. Like I mentioned in the beginning of this video, a lot of these lymphocytes, they grow and mature and train and change. So if they develop a cancer sort of halfway through their change, it might be difficult to put them in one basket or another. So when somebody gets diagnosed with lymphoma, what information do we need when we first meet somebody? What kind of things are we going to be requesting and trying to gather? So I think the all of the information has to lead into this question of how bad is the lymphoma, because whenever we want to decide how to treat a lymphoma, we have to talk about, what are we trying to avoid? What are we trying to gain by treating the lymphoma? And then we have to balance the side effects of the treatment versus the side effects of the lymphoma itself. So first of all, there is the diagnosis, the name of the lymphoma, which is what we also mentioned, indolent versus aggressive. So if it's one of those lymphomas that we know is slow growing, that would take years and years to grow just an inch or two, that's a whole lot different than something that we know would double in size in a week or two, for example, that we need to act on now. So that is usually we can that information is gathered by experience of people who have had the same type of lymphoma in the past, and we sort of know and we can predict the clinical behavior. Sometimes we need to ask the pathologist for some more information, genetic tests, extra stains, proteins on the surface of cells or proteins inside the cells to know exactly, subcategorize these lymphomas and try to predict how they're going to behave. A second way to look at sort of how bad it is stage. And in lymphoma, stage is not as important as in other types of cancers, such as, lung cancer, for example. However, it also kind of tells us where is the lymphoma at, how widely has it spread. And so to get that piece of information, we use scans to look inside the body, such as a PET or a PET scan or a CT or CAT scan. Sometimes we need to look inside specific organs, so we could do a bone marrow biopsy to look and see is there a lot of lymphoma in the bone marrow or none at all, and it just originated in a lymph node. And sometimes we do a lumbar puncture, and that is to get a small sample of the fluid that surrounds our brain and spinal cord. Some types of lymphoma do have a predilection to go into that space, and we have to make sure whether or not it is there. And sometimes we have to biopsy other organs if we suspect that there is lymphoma inside those organs. Another very critical and important piece is how well does a person feel, and how well has a person been feeling over the course of the last several weeks to months. And that can involve a lot of questions, such as what were you doing on the 4th of July and what were you doing last Christmas? It is really important to see how the lymphoma has affected somebody's body and energy and strength. We also do some blood work to look at the organ function, kidneys, liver, and we do look at other organs in different ways with ultrasounds or more scans, for example. So what are the different types? Let's start with the most common type of non-Hodgkin's lymphoma, which is B-cell non-Hodgkin's lymphoma. This is almost 80% of all non-Hodgkin's lymphoma, and there are many, many different types. These are the most common and the majority of the types. I listed them out here. So CLL, or chronic lymphocytic leukemia, or small lymphocytic lymphoma. This is essentially the same disease. If it's in the blood and liquid, we call it leukemia and CLL. If it's in the lymph nodes and solid, we call it SLL. And sometimes it can go back and forth, and sometimes it can be both at once. So this is one type of lymphoma. Another type is called marginal zone lymphoma, MZL. And again, this can be found in different organs and have different names. For example, if it's in the stomach or sort of around the glands in the eyes, it's called multilymphoma, and it's the same cell, it's the same marginal zone lymphoma. Waldenstrom's macroglobulinemia is another type. A different name is lymphoplasmacytic lymphoma, LPL. Follicular lymphoma is one of the most common types of non-Hodgkin's lymphoma. Mantle cell lymphoma, then diffuse large B cell. So this is the most common subtype, with follicular lymphoma being a very close second. DLBCL and follicular lymphoma are about 2/3 of all types of B cell non-Hodgkin's lymphoma. There is a new name for diffuse large B cell when it has certain mutations that make it a little bit more aggressive. It's called high-grade B-cell lymphoma. Another rare subtype is called Burkitt's lymphoma, and then lymphoblastic lymphoma. So the order by which I listed these out, we do start with some of the more indolent, less aggressive ones, and then we do end with the more severe, more aggressive ones, even though it's not a clear-cut straight line, but just kind of a general categorization of these. And like I mentioned initially, there are some rare subtypes, PTLD, post-transplant lymphoproliferative disorder, and this can be more than one. It can sort of be on a spectrum itself. PBL, or plasmablastic lymphoma, is also another rare subtype. And then, these gray zones where it's in between one type and the other. What about T-cell lymphoma? So for the T cells, it is a little bit more complicated. They are more rare. They're about 15% of non-Hodgkin's lymphoma. They're less organized because we don't know exactly how they form, and some of them are named by location. Some of them are named by shape, and some of them are named by how they behave. To give you an example, CTCL is cutaneous T-cell lymphoma, so it is lymphoma in the skin, but we know that that lymphoma can start in the skin and go to other places, but we still call it CTCL. PTCL is sort of the main classification. It's called peripheral T-cell lymphoma, and it does include several subtypes. And a lot of times, like I mentioned, it's really tough to differentiate between these subtypes. Some of the common ones: AITL, angioimmunoblastic T-cell lymphoma; ALCL, anaplastic large cell lymphoma; EATL, enteropathy associated, and others. PTCL NOS. NOS means not otherwise specified. So this is sort of a basket. This is kind of the gray zone of T-cell lymphomas, or a category by which we cannot, we do all the tests that we need to do, we do all the scans, and we still cannot say that this is one or the other. It doesn't really fit that box, so we call it PTCL NOS. As we learn more and more about these lymphomas, we are diagnosing less PTCL NOS and more of the others, including sometimes describing some other novel ones. And then there are also some of the mixed types, like extranasal ENKT, or extranasal natural killer T cell lymphoma. And then there are some very rare NK type of lymphomas. These are less than 5%. Now, how do we treat lymphoma? It really depends on the stage, but for the vast majority, it will include chemotherapy. Chemotherapy given in the vein, because lymphoma is a cancer of the blood, so we have to put the medicine in the blood. Very rarely we use radiation, and even more rare do we use surgery to try to cut everything out. It is fairly rare to do that. Sometimes we don't treat it at all. For some of these indolent lymphomas, where we know it's not going to cause a whole lot of trouble, and then we just discover it or diagnose it incidentally. Somebody's getting a scan for a totally unrelated cause, and then they found some lymph nodes, and they do a biopsy, and they have an indolent type of lymphoma. A lot of times we just try to watch and wait to these lymphomas. Now, whenever we do treat or not treat, there is some kind of response assessment, or how do we monitor? How do we make sure that the lymphoma isn't coming back or growing or changing rapidly or switching types? So that is done usually. We have these schedules that are fairly standard. When we first find out about a lymphoma, we try to see them a little bit more often than once we know the person for a couple of years, because it allows us, it's a sort of a period of education where we're trying to learn how this lymphoma is behaving. And the way we do that, we see somebody, we ask them how they're doing, we do a physical exam, we try to feel for the lymph nodes, we get blood work, and sometimes we get CT scans or PET scans. And so this is sort of the follow-up. After we decide on doing something, we follow up to make sure that whatever we decided was the right decision and it's working. Now, finally, sort of, I think, especially after COVID, I spent a lot of time in my clinic talking to patients about the risk of infections with lymphoma. So we did mention initially that lymphoma is sort of closely tied to the immune system. It is a cancer of the white blood cells, and white blood cells are the units that make up our immune system. And we also mentioned that lymphoma is a little bit more common in people who have issues with their immune system. So we know for a fact that somebody with lymphoma probably has a small amount or a small degree of immune dysfunction. And when we want to treat lymphoma, we use medicines and chemotherapies and agents that would disrupt the white blood cells. Now, we do try to be smart about them. The more advanced medications that we use are a little bit more targeted, but some are not. And even with the targeted ones, we do get some friendly fire, and we do get rid of some normal white blood cells. And when we do that, the risk of infections in individuals goes up. So we always ask them to be very careful about things, and we ask them to be very cautious about getting exposed to infections. So I might do another video about infections in patients receiving chemotherapy later. But for now, this is it. And so, let me know what you guys like to talk about. And like I said, please leave comments in the comment section. Thank you.